Today we're going to discuss diagnostic considerations in presumed Takotsubo cardiomyopathy. My name is John Wagner, and I'm an internal medicine resident at Rush. Let's start with our case presentation. A 91-year-old female presented with 1 week of nausea, vomiting, and failure to thrive. She denied chest pain and shortness of breath, but did have some intermittent abdominal pain. She had minimal PO intake over the preceding 5 days before admission, after she learned her son was moving out of state. Her past medical history includes hypertension, diabetes, depression, diastolic heart failure, and stage 4 chronic kidney disease. As for objective data, her labs were significant for a serum creatinine of 3.11, around a baseline of 1.50, and her elevated troponin was also noted to 1.72, which downtrended on repeat readings. Initial EKG showed ST elevations in the anterolateral and inferior distribution, and a CT abdomen pelvis was ordered in the emergency department due to the patient's abdominal pain. It incidentally showed severe atherosclerotic vascular calcifications in the coronary arteries. That's pictured here in the center of the screen with the green arrow. Bedside ultrasound showed a newly reduced ejection fraction to 20 to 25%, down from 55 to 60% 1 year prior. And those images are shown here, again in the center of the screen, with characteristic apical ballooning present in the left ventricle. You can see in both systole and in diastole there's minimal wall motion. That brings us to our diagnosis. That apical ballooning I talked about is highly suggestive of Takotsubo, hence the meaning of Takotsubo in Japanese, octopus pot. You can see the resemblance in a patient's affected left ventricle with Takotsubo on the ventriculogram pictured here. What are some other features of Takotsubo? Elevated troponin is usually present, decreased left ventricular function, and left ventricular wall motion abnormalities, of which there are 4 subtypes, apical ballooning being the most common. Multiple different diagnostic criteria have been suggested for Takotsubo, with the Mayo Clinic version being the most common and listed here on the left panel. But diagnostic criteria alone, however, are insufficient. Patients with presumed Takotsubo, for instance, may have underlying acute coronary syndrome present, and it should be noted that definitively diagnosing Takotsubo requires coronary angiography. Interestingly, a recent study determined after controlling for comorbid conditions that presumed Takotsubo patients who do not receive angiography are at multiple-fold higher risk for a poor in-hospital outcome. That data is shown here in the left panel in the lower corner. And with increasing age, this difference becomes more pronounced, especially after age 61. So should every presumed Takotsubo patient get a cath? Let's go back to our case. After discussing the risks and benefits of coronary angiography, patient or family ultimately declined, citing it was not congruent with their goals of care. She received medical optimization for her heart failure, and she was discharged with home health care assistance. So while our patient did not end up getting a cath, her case demonstrates the clinical challenge of definitively diagnosing Takotsubo without the benefit of coronary angiography to exclude ACS. Some risks and benefits that go into that decision are listed here on the right panel. Procedural complications, patients with comorbidities including renal failure, such as our patient, and a low pretest probability of ACS being not that useful even if you do confirm Takotsubo are among the risks. As for the benefits, you can have a decreased mortality based on the data we have if you don't get cath. And there's a definitive confirmation of Takotsubo via cath. And if there's a high pretest probability of ACS, the revascularization benefits usually outweigh the risks. Beyond coronary angiography, are other less invasive imaging modalities capable of improving the discrepancy of in-hospital outcomes for presumed Takotsubo? CT coronary angiography and cardiac MRI are intriguing modalities that may help elucidate a Takotsubo diagnosis, or at least rule out other etiologies such as ACS or infectious myocarditis in patients who may not be candidates for coronary angiography, but further study is needed in this area. Thank you for your attention.